Bismillahirrahmanirrahim. Now we will discuss the investigations required for the diagnosis of Sjogren syndrome. Firstly, we have the test measured the following parameters: stability of the tear film by the breakup time (BUT). Tear film breakup time decides the tells about the stability of tear film. Tear production will be checked by Schirmer, and the fluorescein clearance and tear osmolarity and ocular surface diseases confirmed by the corneal stains and the impression cytology. Now, what is that? If there is a poor correlation between the symptoms and the clinical test in patients with dry eye syndrome, however, the reliability improves as the severity increases. So we have the test, that is the stability of the tear film, then tear production, and as well as for the ocular surface disease. First of all, there is a tear film breakup time TBUT. It is measured by abnormal in the aqueous tear deficiency and meibomian gland disorders. Fluorescein 2% is instilled into the lower fornix, or the impregnated fluorescein strip moistened with the non-preserved saline. Patient is asked to blink several times. Tear film is examined in the slit lamp with a broad beam using the cobalt blue filter. After an interval, black spots appear in the fluorescent stained film, indicating the formation of dry areas. So, VUT is the interval between the last blink and the appearance of the black spots or the dry spot. Development of dry spots always in the same location may show the corneal surface abnormality. Let's see the figure 5.8. So, this is the tear film break A1. Showing the tear film breakup time. Numerous dry spots are visible on the fluorescein stained tear film. These are the dry spots that are forming. Now back to the Schirmer test. We have discussed the tear film breakup. Now on the Schirmer test. Schirmer test is useful for the assessment of the tear film production, aqueous tear production. And we use the number 14 Whitman filter paper, 5 mm wide and 35 mm long. Test is used to perform with or without the topical anesthesia. So, in practice, topical anesthesia cannot abolish all the sensory and psychological stimuli for reflex secretion. However, in theory, anesthetic basic secretion is measured, and without anesthetic Schirmer 1, it measures basic plus reflex secretion. So we are having the procedure as follow. Excess tears are delicately dried. If topical anesthesia is applied, the excess should be removed from the inferior fornix with the filter paper. फिल्टर पेपर ये एक न्यू पॉइंट है कि पहले जो एक्सेस टीयर्स हैं उनको ड्राई कर लिया, जो टॉपिकल एनेस्थीसिया अप्लाई किया तो एक्सेस शुड बी रिमूव्ड फ्रॉम द फोर्निक्स विद द फिल्टर पेपर. फिल्टर पेपर इज़ फोल्डेड 5 mm फ्रॉम वन एंड उसको रख देते हैं आंख के अंदर इन द मिडल एंड द आउटर थर्ड ऑफ द लोअर लिड. मिडल एंड द आउटर थर्ड के दरमियान रख देते हैं और टेकिंग केयर नॉट टू टच द कॉर्निया और लैशेस. Patient is kept asked to keep the eyes gently closed, and then after 5 minutes we keep the filter paper removed and amount of wetting from the fold is measured. If it is more than 10 mm, then it is normal, and less than 10 mm of wetting after 5 minutes without anesthesia or less than 6 mm with anesthesia is considered abnormal. Results can be variable. And then the next one is the figure. See the figure 5.8b. So let's see figure 5.8b. So here is the Whitman filter paper, which is 5 mm wide and 35 mm long. 5 mm is folded and then placed inside the between margin of the lower lid middle part and the outer third part. And after 5 minutes it is observed if more than 10 mm is covered with the tears, it is normal. If less than 10 mm, then it is abnormal. And C is showing the corneal and conjunctival staining with rose bengal and with the fluorescein. Now the next test is the ocular surface staining with the fluorescein, with the rose bengal, with the lissamine green stain, and pattern of staining may diagnose the disease. So let's see, fluorescein stains cornea and conjunctival epithelium where it is insufficient damage to allow the dye to enter the tissues. Rose bengal is the dye that has an affinity for dead or revitalized tissue that have lost or altered mucus layer. Corneal filaments and plaques are shown clearly, and use of red-free filter will help the visualization. 1% solution of rose bengal or moisture impregnated sim strip can be used. The dye may cause intense stinging that can last for up to a day, particularly in patients with severe keratoconjunctivitis. To minimize irritation, a small drop should be used. Immediately proceeded by drop topical anesthetic. Lissamine green stain show similar fashion but cause less irritation. Preferred use. Pattern will show the diagnosis. Interpalpebral staining of the cornea and conjunctiva is common in aqueous tear deficiency. Interpalpebral staining of the cornea. Superior conjunctival stain may indicate superior limbic keratoconjunctiva. Inferior corneal and conjunctival stain is often present in patients with blepharitis or exposure. So see the figure 5.4. So this upper one is the stain with the conjunctival staining with the rose bengal, and the lower one is with the lissamine green stain. And corneal signs dry eye 5.8, corneal and conjunctival staining with the rose bengal with the fluorescein. Other investigations: fluorescein clearance test, and the tear function index may be assessed by replacing 5 microliter of fluorescein ocular surface and measuring the residual dye in Sherman strip placed in the lower lateral test intervals. Another test is tear film osmolarity, which have the marginal range of 305. Dry eye syndrome varies from 305 and 316 depending on the degree of tear film instability. Threshold value is a widely accepted threshold value is 308, and a value of 316 appears to discriminate between mild and moderate. Tear constituent MMP9, that is matrix metalloproteinase 9, and decreased lactopherin also show the presence of elevated MMP and decreased lactopherin in dry eye. Phenol red thread test and tear meniscometry and impression cytology are some other tests required for the diagnosis of dry eye disease.